Glenohumeral joint dislocations can occur in four primary different directions. Anteriorly, which is usually due to a blow to the posterior lateral shoulder. The shoulder is oftentimes in abduction, external rotation, and extension. Posteriorly, where the humerus is flexed and internally rotated and receives a posterior force along the long axis of the humerus. Inferiorly, and people can also have a multidirectional dislocation or a multidirectional instability, and this occurs when damage is taking place in more than one plane. In order for the glenohumeral joint to have stability, it requires both passive and dynamic components to maintain the proper alignment and function. And this is an inherently unstable joint, and so this dynamic and passive stability becomes very important. When we think about the passive stabilizers, these are things that are not contracting. There is very limited glenohumeral joint volume and a negative joint pressure. And so you have approximately 27 milliliters of synovial fluid in the glenohumeral joint. So the weight of your humerus actually creates a vacuum. Think about a plugged syringe. As you pull that open, it gets harder to pull it open because of that vacuum that is holding it in place. The same type of thing occurs in the glenohumeral joint. There's also concavity compression of the glenohumeral joint, and the humeral head compresses on the glenoid fossa or labrum. And the glenoid labrum itself constitutes the fibrocartilaginous rim of the glenoid. The glenoid depth is doubled, and so the labrum acts as a chock block, and it provides attachment of the glenohumeral ligament and the long head of the biceps tendon. Additionally, you have joint capsule and ligaments of the glenohumeral joint. The superior glenohumeral ligament extends from the anterior posterior edge of the glenoid to the top of the lesser tuberosity. Along with the coracohumeral ligament, it limits inferior translation of the humerus and external rotation of the adducted shoulder, as well as posterior translation of the flexed, adducted, and internally rotated shoulder. The middle glenohumeral ligament originates from the supraglenoid tubercle and superior labrum and attaches to the base of the lesser tuberosity. This ligament limits anterior translation of the humerus when the arm is abducted between 60 and 90 degrees. The inferior glenohumeral ligament has three distinct parts: an anterior band, the axillary pouch, and a posterior band. This inferior ligament extends from the anterior inferior labrum glenoid to the inferior surface of the humeral head, inferior to the middle glenohumeral ligament. It functions like a hammock in preventing increased translation of the humeral head on the glenoid. So during abduction, the entire complex moves beneath the humeral head and becomes taut. When the shoulder internally rotates, the complex moves posteriorly and limits posterior translation. And when this joint externally rotates, the complex moves anteriorly and limits anterior translation. Your dynamic stabilizers of the GH joint are more active stabilizers. We have dynamic ligament tension that takes place. This is the main role of the rotator cuff tendons, which blend with the shoulder capsule. Their job is to tighten on contraction. The tensioning of the capsule complex helps to restrain excessive humeral head translation. There's also muscle coactivation, which we call force couples. The subscapularis co-contracts with the infraspinatus and teres minor. These three muscles will center and compress the humeral head into the glenoid fossa. The infraspinatus and teres minor will co-contract with the deltoid and supraspinatus, also to keep the head centered. So if we look at this chart on the dynamic stabilizers, we can see exactly at the different joint angles, 0 degrees anatomical position, what our stabilizing structures are. You have muscles that are stabilizing along with those ligaments at each of the different angles. In addition to our passive and dynamic stabilizers, we have our sensory motor control system. This encompasses all of the sensory, motor, and central integration and processing components of the central nervous system involved with well-balanced muscle activation to provide stability at the shoulder joint. Keep in mind that includes both proprioception and kinesthesia. So the sensory information input from the glenohumeral joint ligaments and joint capsule, musculotendinous structures, and cutaneous structures are all going to function to maintain that joint stability. So when we talk about anterior dislocations, we need to think about what's actually happening. Generally speaking, the mechanism of injury is going to be the shoulder in abduction, external rotation, and hyperextension. The acromion acting as a fulcrum about which the humerus is rotating. When we have this type of dislocation, we end up potentially having structural injuries in addition to the actual dislocation. A Bankart lesion may occur, and that is an avulsion of the anterior joint capsule and glenoid labrum from the anterior rim of the glenoid fossa. We will see anterior joint capsule and inferior glenohumeral ligament attenuation, so we've got a gradual loss of intensity of that ligament. Or we may see a Hill-Sachs lesion, and that occurs when a posterior border or rim of the humeral head impinges on the anterior rim of the glenoid fossa during anterior dislocation, resulting in an impact fracture, a vertical fracture on the posterior rim of the humerus. Signs and symptoms include a vacant glenoid sign. This is very key to the clinical evaluation. You'll see a step-off and a very prominent acromion process. The humeral head will be sitting in the axilla. It's obviously very painful. The person will be dysfunctional, and the person will look like they're holding a dead arm. Range of motion in the glenohumeral joint is going to be extremely limited in both active and passive range of motion. Neurovascularly, you will want to check the brachial plexus as well as the radial artery. Diagnosis will be clinical in many cases, but an X-ray may be performed to rule out a fracture. Treatment-wise, for the initial injury is to immobilize and stabilize in the position of the dislocation. If you have been trained, you can also reduce an anterior dislocation. Post-reduction risk of dislocating is very high in younger people, and you can see from this chart as you get older that becomes less. And main reason that this becomes less is the fact that the older you are, the less active you tend to be. Treatment-wise, there are several surgical procedures for correcting the instability. The Bankart procedure is the gold standard. It will be used to repair the Bankart lesions. There's also a Putti-Plat, the Magnuson stack, and the Bristow procedures that may take place, as well as laser surgery.